So my name is Ila Saunders. I'm faculty here at UCSD at the School of Pharmacy, and I'm also an oncology clinical pharmacist at Morris Cancer Center, where I work with Dr. Goodman as well as other physicians. And I've been in malignant hematology as well as blood and marrow transplant for about almost 15 years now. And my story in getting into Erdheim-Chester disease and learning about it was largely because I had the opportunity to work. I'm good. Sorry, I know you can't see me. I'm used to that. Do you want me to move it down?
No, that's
okay. In Dr. Kurzrock's clinic with Dr. Goodman, and had the opportunity to take care of a lot of patients that had this disease. And so what I'm going to focus on today is largely on the targeted therapies that we use for treatment. And so when we think about, my hope that by the end of this talk, you'll be able to list the targets, which I'm sure many of you have already learned, and Dr. Goodman set me up really well for that, and also identify the therapies we use, as well as outline the side effects and monitoring, which I'm sure many of you are interested in, and finally review the management and monitoring of many of these side effects. And so to give you a sense of what we'll talk about today is the therapy summary for ECD, the common side effects, how to deal with drug-drug interactions, and then finally questions to ask your oncologist or your pharmacist. And so when the physicians decide to treat ECD, they've gotten the diagnosis, which I know can be incredibly frustrating because it takes such a long time to actually get the treatment, get the disease diagnosed at times. And when thinking about treatment, it's important to take into mind the symptoms, the gene mutations that Dr. Goodman talked about, as well as comorbidities, which means what diseases do the patients already have when they're coming into treatment at this time. And then we know too that Erdheim-Chester disease can affect the long bones, like Dr. Goodman mentioned, as well as the heart, the lungs, the kidneys, the skin, the brain. And so all these things need to be taken into consideration when thinking about initiating therapy for ECD. And when thinking about the treatment, the goal is really to decrease toxicity and maximize the efficacy of the treatment. And what does that really mean? We want to decrease the side effects. Ideally, we want to be able to decrease the cost as well, and also stabilize the disease and hopefully improve it and really improve the quality of life of our patients. And so when thinking about the molecular testing that's already been discussed, we know that about 50% of all patients with ECD have a BRAF mutation. And if there's no evidence of this BRAF mutation for the V600E, we would do a targeted next generation sequencing to look for other mutations, like Dr. Goodman already mentioned. And about 40% of these patients with no BRAF mutation will have a mutation in this MAP kinase pathway. And in thinking about the drug targets, we know that these mutations actually affect the cell proliferation and survival. And like I shown here, we have the majority of patients have this BRAF V600E mutation, followed by the MAP kinase, and then some even have this KRAS and NRAS mutation as well. And then what we also see is other mutations that also show up, such as in the ALK pathway, as well as mTOR. We can sometimes use mTOR inhibitors as well. But what I want to focus on today is these advances in therapy. With this advent of next generation sequencing, we know now that our patients have these mutations. We've largely moved from using traditional immunosuppressive therapies, cytokine-directed therapies, as well as conventional chemo, the anakinra, the cladribine, the interferon, to targeted therapies, BRAF inhibitors, MEK inhibitors, and in some cases, combinations of BRAF and MEK inhibitors. And so we're moving towards targeted therapies. And so I'll focus on the BRAF inhibitors, Vemurafenib, Dabrafenib, as well as MEK inhibitors, and drugs, the Cobimetinib, Treatment that can target KRAS, NRAS, as well as mutations in the MAP kinase pathway. So I'm going to jump into what I think you're all interested in is how is it dosed? What are the adverse effects? What kind of things need to happen before you start treatment and then during treatment as well? What you'll notice in the treatment of ECD is that patients need to really start out on these much lower doses, anywhere from 240 to 480 milligrams given twice a day. And I'll talk a little bit about why that is. What you'll notice, however, is if you look at the package insert that the drug companies put out, is that the dose that's actually recommended is 960 milligrams twice a day. And Vemurafenib is the only BRAF inhibitor that is FDA approved for ECD. And adverse effects that we see in our clinic are frequently rash, bone pain. We can actually get changes to the electricity and the electrical activity of the heart, as well as hair loss, as has been mentioned already by some patients here, fatigue, as well as development of some skin tags. So before treatment, to monitor all of these, a skin exam is incredibly important, as well as looking at blood sugar, electrolytes, liver function, kidney function as part of a complete metabolic panel. And then during treatment, our clinic, we check the electrocardiogram at 15 days after treatment, monthly for 3 months, and then every 3 months thereafter. A skin exam is incredibly important every 2 months. In addition to that, let's just say you stop treatment because maybe the drug isn't working or experiencing toxicity. It's important to have another skin exam 6 months after stopping treatment as well. In addition to that, getting a complete metabolic panel 15 days after treatment and then monthly. Many of these drugs cause a lot of sun sensitivity. And I know many of you are probably enjoying San Diego and the weather here, but it's really important to wear long sleeves, hat, SPF 30 sunscreen, and because it can cause a lot of sun sensitivity, this drug. And so what I also want to highlight here, I don't know if these slides will be provided to everybody, but I have links at the bottom of each of these slides. And these are oral chemotherapy med sheets that I actually give my patients that give a great detailed description of what to expect and how to handle some of these side effects. And then we also have the BRAF inhibitor, Dabrafenib. With this, what we most often see, especially when it's given in combination with some of the MEK inhibitors, is fever as well as fatigue. Some patients can actually get skin thickening in the palms and soles of their feet. It can decrease phosphorus levels as well as cause headache and visual changes. And so similar to the Vemurafenib, a complete blood count as well as a complete metabolic panel and a skin exam is incredibly important at baseline, followed by an ophthalmology exam once treatment is started, with a skin exam as well, and a complete blood count and a complete metabolic panel monthly. And I will say that some patients, once they've gotten several months out of treatment, your doctor may not do this exactly. This is what we do in our practice. They may stretch out the monitoring of the complete blood count as well as the complete metabolic panel to every 2 months, to every 3 months if you're really stable. And then thinking about the MEK inhibitors. So what's really unique about the MEK inhibitors, and why some of you who are on this treatment may require measurement of an echocardiogram, which really measures how strong the heart function in the left ventricle is primarily because that pathway that I showed you, that ERK and MEK pathway, actually protects the heart. So when you inhibit those pathways to treat the Erdheim-Chester disease, that can result in cardiac dysfunction, so dysfunction of the heart function itself. And so that's why in patients receiving these MEK inhibitors, you actually need monitoring with the echocardiogram at very specific intervals. In addition to that, we know that the Cobimetinib can impact the muscle, and so we need to check the creatinine phosphokinase. You can see that here listed as the CPK at regular intervals. And we also know that it can cause eye toxicity. So an ophthalmology exam is incredibly important soon after starting treatment and then at regular intervals after treatment. And again, this can also cause sun sensitivity as well. And then finally, we have Trametinib here, which you'll notice what's unique about Trametinib, and I always talk to my patients when I see them at baseline education and see them at regular intervals throughout therapy, is that they're storing it in the fridge. I had a patient in my other clinic who actually left the Trametinib in their hot car, and so unfortunately that drug was no longer stable and we had to order a new order of medication. So really important to store the Mekinist or Trametinib in the fridge. And then side effects of Trametinib that we see are very similar to that of Cobimetinib, but you can also get diarrhea, rash, and swelling with this drug. And this can be because you're also inhibiting that same pathway that's cardioprotective, and that's why we need to monitor the echocardiogram at a regular interval. And then finally, what you may notice is that these FDA-approved doses of targeted therapy are much higher than what maybe you're getting right now, or what I'm saying you should start the dose at. And this is largely because patients with ECD can't tolerate these full doses of therapy. In that VE basket study by Dr. Diamond and colleagues, all 26 patients on that study actually had adverse effects that led to dose adjustments or modifications, and about 8 patients actually had to stop the Vemurafenib because of these adverse effects. And we actually saw this in our own study that I did with Dr. Goodman and Dr. Kurzrock when we looked at our patients in our clinic. All 10 patients actually got 25 to 50% of that total FDA-approved dose of these MEK and BRAF inhibitors, but they actually had really good responses. So despite having side effects, despite requiring much lower doses of these BRAF and MEK inhibitors, about 80%, so 8 of these 10 patients achieved a partial remission to therapy. So what I want to encourage you to do is, if you are starting these therapies, or you have a patient or a patient in your support group that's starting these therapies, it's important that you maybe don't start at this very high dose. You start at a lower dose so that you can start low and go slow to make sure you're tolerating it. And this can be incredibly confusing because I've mentioned some of these drugs can actually be given daily. Some are given for 3 weeks on, 1 week off because of various toxicities. Some need to be given on an empty stomach. Some are given with food. So it can be incredibly confusing. So what I want to encourage you to do is talk to your clinic team, get extra support if you need it from your pharmacist, if you have one. If you don't have one, ask your physician for one. I'm totally tooting my horn for my profession. Oncology pharmacists are an excellent resource to help make sure that your side effects are being managed and can work closely with your clinic team to help that. So let's move on to side effects real quickly. And I want to shift gears and talk about what should you do about these side effects. And so what I have here for you is just lists of how to actually deal with some of these side effects. That said, if they do get severe, it's important to contact your clinic team. These are for very mild situations. So if you're concerned about a rash, I encourage you to use unscented creams, avoid perfumes, colognes, and avoid being in the heat for really long periods of time. And I've talked a lot about sun sensitivity. It's important to avoid sun exposure, especially with the drugs that can increase your sun sensitivity. Like I mentioned, long sleeve clothing, UV protection. The highest exposure to UV radiation is between 10 a.m. and 4 p.m. Maybe avoid the sun during those times and use broad spectrum SPF 30 sunscreen. I do go over all of this when I talk to my patients at baseline before they start treatment, and then reiterate this at every visit. In addition to that, we know that some of these treatments cause GI side effects. I also encourage you, when you're starting these treatments, let your team know what is a baseline bowel movement for you. If your regular normal bowel movement is 1 every 3 days, and then you go to 2 bowel movements every day, that would be concerning. If your normal is 2 bouts of diarrhea every day at baseline, and then you're still having 2 when you're having treatment, I'm less concerned. So it's important for us to understand from a bowel movement perspective what's normal for you, and also to know when would you contact your team. For example, if you start having watery loose stools for 24 hours, we want to know about that. And that's what we consider diarrhea, because if that's happening, that could be a sign of infection. It could be a sign of a side effect of the treatment as well. And in these situations, there are things you can do at home if it's mild, of course. Eat, the brat diet, which you may have heard of before, the bananas, rice, applesauce, toast, very bland foods to actually help with your diarrhea. Avoid things that can actually irritate your gut, lactose-containing foods, spicy fried foods. In addition to that, some of these treatments can actually also cause some nausea and vomiting. In the grand scheme of like the armamentarium we have for chemotherapies, I would say these treatments are on the lower to minimal end of causing nausea, but it can still happen. So if you have been given anti-nausea meds by your team, I would encourage you to take it when you start feeling that twinge of nausea. Don't wait till it gets out of control to take the nausea medicine. And then when we're talking about cardiac side effects, and I know that can sound incredibly scary, but the good news is that our teams are monitoring your heart very closely when you're on medications that can affect the heart. That said, things to watch out for when you're at home If you feel your heart beating irregularly or you feel faint, lightheaded, or dizzy, that's when you should contact your team. If you notice swelling of the hands or feet, shortness of breath, weight gain of 5 pounds or more in a week, that could be a concern of when your heart function is not as strong as it was prior to starting treatment. And then finally, there is an infection risk with some of these treatments, specifically the Cobimetinib, because we know it can affect the white blood cells, as well as the red blood cells and the platelets. And so our teams will monitor your labs regularly. And each clinic probably has their own monitoring parameters and own duration that they do this. So what they will do is look at this regularly. And what you may feel if you have a low hemoglobin is a feeling of tiredness, low white blood cells, increased risk of infection. So it's important to stay away from people who are sick. This does not mean to stay away from your support system, but if they are sick, to stay away from them. And finally, low platelets can increase your risk of bleeding as well. And so how do we manage this? So we have a very specific way we think about this. We utilize something called the clinical toxicity criteria of adverse events. And each drug has very specific recommendations on how to manage these side effects. And to help you understand how we do this, if a side effect is intermittent and mild, we'll just monitor it over time. If it starts to become intermittent, but it persists for long periods of time, at that time, we may want to treat it. If it becomes chronic, persistent, and is more of a moderate side effect, at that time, we may consider if it's interrupting activities of daily life or just affecting you overall, we would want to consider dose adjusting. And then finally, if it's chronic, persistent, and this side effect is severe, it's at that point we'd want to hold therapy. And so to kind of give you an example to put into perspective, there's a patient I see with Dr. Goodman who is on Cobimetinib, who I'm monitoring, and she actually had an increase in that level, the CPK level, for example. And we were debating, is this a level that we would need to change the dose? Fortunately, she had 0 symptoms of muscle pain, muscle weakness, so we were just continuing to monitor. Similarly, if a patient has a rash that's mild, intermittent, shows up here and there, we're probably just going to monitor it. If it becomes persistent over time, we may consider, okay, we might need to treat with a steroid cream of sorts. And then if it becomes chronic to a point where it's affecting their activities of daily life, potentially spreading, we would consider dose adjusting the medication. And then finally, if it becomes chronic, persistent, and severe, the rash is so severe, it's at that point we would consider holding therapy. And then finally, it's really important to think about drug-drug interactions. And what I want to highlight here is there are foods that can interact with the Dabrafenib, Vemurafenib, and the Cobimetinib. And it's the grapefruit juice that you, I'm sure, have heard of, but other things like pomegranate. And I want to point out Seville oranges, not your run-of-the-mill oranges. And I highlighted the Seville oranges here because my patients sometimes think they can't eat any oranges, but it's specifically the Seville oranges. And there's a compound in the skin that's used to make marmalade. So if you eat a lot of orange marmalade and you're on any of these treatments, I would stay away from it. Azole antifungals, things like fluconazole, voriconazole, posaconazole, and there's a whole host of other antibiotics and other drugs that are listed here that are used for the heart function as well. The one thing I really want to highlight here that is the star is the ritonavir. And this is incredibly important because that's a component of Paxlovid, which is now being used to treat COVID-19. And that can severely increase the levels of the drug to the point where it can become toxic. So if you at any point or your patient or a caregiver ever needs, if your family member needs Paxlovid, please let them know that you are on a drug that can be impacted by the ritonavir, because there's very specific recommendations we have on how to hold treatment and when to, at a specific time, when to resume it, because the ritonavir lasts in your system for quite a long time. So you can't actually resume your treatment of ECD until at least 5 days after you stop the Paxlovid treatment. So please keep this in mind if you ever need Paxlovid. And so where are we at with the future of ECD therapy? I looked on clinicaltrials.gov earlier this week, and I was happy to see there's 2 trials that are recruiting, one locally in the United States that's looking at a new ERK 1 and 2 inhibitor, And then there's one in Asia and China that's looking at another BRAF V600E mutation. I'm sure we're all waiting on these results of this phase 2 study of lenalidomide. It's more of an open label study on histiocytic disorders, looking at lenalidomide in this patient population. It's not recruiting anymore, but I'm sure that data is forthcoming. Finally, what I want to do is give you an army with a lot of questions to ask your team. And this is really to help make sure that you have all the knowledge you need to move forward with your treatment, whether you're staying on the treatment you're on, whether you're changing treatments. And I have a whole list here that I hope will help you, such as why are you on it? What can you change how you take the medication? How do you take the medication itself? Is it on an empty stomach or with food? Does it interact? That's a hugely important question. And then finally, interact with foods, herbal supplements, what side effects can you expect? And then finally, other questions to ask. What do you do if you miss a dose? And then I think one of the most important things that we tend to think about a lot on the pharmacy side is, what is the cost? And I know that can often be a challenge with Vemurafenib being the only one that's actually FDA approved and requiring several hoops to jump through to get some of the other drugs that we know work, but don't always have the FDA approval for. I know I ran through that quickly, so I will pause now. I'm happy to take any questions. Yeah.
I think part of my experience will relate to your experience. Like Barry, I was on a combined therapy of a kinase and MEK inhibitor. It was Dabrafenib and Cobimetinib. And this resulted, actually, my wife Susan related this, I'm elaborating on it a little bit more. We went on this medication because after the NIH trial, which was a phase 2 clinical trial for these particular medications, about 2 years after starting this treatment, we did have the dosages and they're fairly low. But then I started feeling very, very weak one day, and it was kind of a struggle even walking, which I thought was really strange because I thought, well, gee, I'm now on a very good pair of medications. At that time, my regular hematologist, Dr. Damon, was out of office, so fortunately, we had a longtime neurologist to whom we referred, and he said, well, why don't you stop taking the 2 medications? We can determine if there's some defect in one or both of them. So at the same time, we reached out to NIH, and the researcher there is Kevin O'Brien, and he actually did some research and found that the second drug, Cobimetinib, can have some ill effects and kidney damage, ultimately resulting in rhabdomyolysis. The odd thing, I guess, is that supposedly people will see this kind of reaction at the outset of starting therapy, whereas in my case, it took 2 years, and that was seen as being very, very odd. Now I'm no longer on either Cobimetinib or Dabrafenib. I'm on Zelboraf. It has its own unfortunate drawbacks too. So a lot of the things that you pointed out in your slide, those are things that I've experienced. I have palmar plantar syndrome, and it affects my feet. And since I have poor balance, it's kind of a disincentive to do what I should do, which is walk and exercise. Anyway, thank you very much for your very elaborate display of these side effects. And again, one further thing. Besides reaching out to other doctors, besides the, I guess you would say, the particular specialist who prescribes drugs for you, I'd also like to shout out to all of the caregivers like my wife, who probably is the main reason why I'm still alive after 20 years of diagnosis. So thank you again, doctor.
Thank you. I may not need that. Oh, good night, you guys.
Hi, my name's Barry, and I take Mechanis and Taflinar,
Okay.
right? And I take the Mechanis in the morning, the Taflinar in the morning, the Taflinar at night.
Mhm.
Okay, and I'm gonna dose. I really haven't, I'm not gonna complain about any side effects, right? Because I don't want to complain. But I do get muscle pain. But as kind of being an athlete and growing up and playing sports and stuff, you learn to deal with muscle pain. So life goes on, right? Get the and they're kind of weird things. Like it's almost like you get a bicep injury.
Mhm.
That's weird. Or, but you kind of work through it and life goes on and it's not a problem because I don't want to complain about anything. So I want to tell you about the muscle pain. I think I want to start doing more drug holidays, right? I was doing 2 weeks on, 2 weeks off right after I started, but then my eyes started giving me some problems.
Mhm.
So I went back to full time. And my eyes seemed to get better. You know, maybe it's all in my head, which it is, but so then Dr. Diamond said, well, take some drug holidays when you want. So I kind of take them every so often. I'm on one right now. So, do you have any recommendation other than, 2 weeks on, 2 weeks off? I kind of take, 4 days every month or so here and there. Like when I travel, especially because traveling's a pain because I have to put those little drugs in a little thing and keep them cold. Oh, and speaking of that, how long can they be out of the fridge? Those are my questions.
Okay, so the first question is when should you and how often you should do a drug holiday? That's really hard for me to give a clear answer for because I think every patient's a little bit different of when their symptoms will resume based on how their treatment and their severity of their disease. So it's hard for me to give an exact number of days.
So I do how I feel.
Yeah,
Okay,
I would
fair
do
enough.
it based on how you feel. I could give you more specific answers based on how what we call the half-life of the drug and how long it takes to get out of your system. There's certain things you could do there, looking at what we call 5 times the half-life of the drug, and that'll be completely out of your system by that point.
Yeah, what is that?
For each, I don't have it off the top of my head. I don't know the exact numbers, but given how they're dosed, it's several hours to days, but I couldn't give you the exact number.
It's not weeks, it's more like
No,
days. Yeah,
no.
okay, good, that's good to know.
And each drug is a little bit different because remember they're dosed all differently. Some are daily, some are twice a day.
Mhm.
So they all have different half-lives, and I don't have that off the top of my head. And your second question is about how stable is it out of the fridge? That's a great question. I could look that up and get back to you, but I don't have that. I'll relay that to Jessica.
Okay,
And
that's
get that
good.
for you.
And you talked a lot about sun exposure, which,
Yes.
I haven't had a real problem with that. I wear a lot of sunblock, but, what is the problem with sun exposure? Is it skin cancer or is it like sunburn?
It's sunburn. It increases your risk for getting a burn, and then many of these treatments increase your risk of developing a skin cancer later on. So you want to minimize that risk as much as possible.
Okay, I've eaten up enough of your time.
You've been on both the whole time?
Yeah.
We usually start with one,
Yeah.
but, sometimes, our practice is usually one, and then, I haven't had to use both, so, something to think about too, talking about Dr. Diamond, whether he thinks he can handle maybe just one drug.
And it seems to be working, I'm working great. So.
Yeah, so I don't, you don't want to mess things up that are working.
Hi, I was diagnosed with ECD in 2019. My hematologist in Stanford suggested when I was in New York to see Dr. Diamond. I did. Jointly, they decided I should get on Mechanis, which I did.
Mhm.
I had large growths on both my kidneys. Initially, I was on half a milligram of Mechanis.
Mhm.
Shrank a little bit, but not a lot. So then they put me on 1-2 pills a day. And that worked great. Growths are gone, but my ejection fraction increased. So we now dropped back down to half a milligram a day, which I've been on for a while. So my question is, long-winded question, but the question is, have you seen this in terms of reduced ejection? I know you've seen reduced ejection fraction, but is it reasonable to hope that it will stabilize at my current ejection fraction now that I drop down a dose? Or is it likely that possibly more deteriorates more?
So we have a series of 10 patients that we've looked at in our practice, and I think there was about, I want to say 4 of them had a decrease in their ejection fraction, and then it stabilized. But I can't make a broad generalization to say that yours will, but my hope is if you're asymptomatic at this point and you're continuing to monitor, you'll see the drop if it happens, but it's really hard to predict if it will stabilize. But if you haven't, it hasn't gone down in your next check, then I'm hopeful that it will stay that way at the lower dose.
Thanks. That's the case. I was just wondering what the experience you had with other patients. That's what helped.
Yeah, with Cobimetinib, you'll see about 20% of patients, the decrease in ejection fraction. And almost all of them is asymptomatic, right? Not clinically significant. So I haven't,
Yeah, we haven't
we
seen.
haven't had it clinically,
Nope.
right, we're monitoring, so we're seeing this thing. So, again, to be cautious, we're monitoring, but we haven't seen,
Mm-mm.
I haven't seen, it's reported though, so it's possible. But the majority of them are asymptomatic, just something we see on image,
Right.
which is reassuring.
Yes.
Hi, Susan Lynn. Thank you, Doctor, for your presentation. My question is, with the Vemurafenib and Dabrafenib and Treatment, how long do these medications last in terms of if you store it properly? What is the shelf life of Dabrafenib, Treatment, and Vemurafenib?
The shelf life. So if they're stored properly, it really depends on when the drug was manufactured, when you're getting it, and I would follow the expiration date on the label. I know they're very expensive, and I have several patients that hold on to them in the case they might need it at a later point, but I would follow the label that's on the actual drug bottle itself. It really depends on when it's manufactured. Usually I want to say it's a year after that date. Thank you.